Okay, well, welcome. I am Barbara Fain, the Executive Director of the Betsy Lehman Center, and we are once again happy to be partnering with the Perinatal Neonatal Quality Improvement Network of Massachusetts on this 7th Town Hall on COVID-19 and pregnancy care. So before we get started, I want to mention just a few housekeeping items. And if we go to the next slide. If you are having any technical issues, please just send a chat message to Alex Zhang and she will help you out. The other thing I want to mention is you can use the chat box as we're going along. We'll have our Q&A at the end, sort of in the later part of the town hall, but as you think of questions, just enter them into the chat box. Let us know if your question is for anyone in particular. And then I always like to mention that we do record this meeting so that we can post it on our website, and that includes the chats. So if you have any concerns about the recording, you can send a chat to the Betsy Lehman Center. Your videos will not be included unless you're a presenter. They will not be included in the recording. Okay, next slide. So I always just said this is not a disclaimer, it's more an explanation that we have been sharing, the purpose of these town halls is to share information in a kind of a situation where the ground is shifting under everyone's feet constantly in response to COVID-19. And so, we just, this is information that is, it's up to date at the time, but it is, things are rapidly evolving, so we just encourage you to keep informed of the most up-to-date guidance if you're, when you're thinking about your own internal protocols. Okay, next slide. And always we want to recognize the your needs, not only for information, but for emotional support during these challenging times, and want to make sure that you're available of resources that, make sure you're aware of resources that are available to you. And the Betsy Lehman Center has compiled a number of these, and you can find them on our website at the link below. And again, these slides will be made available after today. So at this point, I am pleased to now pass the baton over to Audra Meadows, who, along with Ron Iverson, co-chairs the Massachusetts Perinatal Quality Collaborative. So Audra, please take it from here.
Hi, good afternoon and welcome everyone. It's interesting to see how far we've come in 8 weeks over the course of beginning these conversations and then moving forward to where we are now. Next slide. To remind everyone, the Massachusetts Department of Public Health, and thank you to Dr. Jot for helping provide this information to us, shows the prevalence of COVID-19 and the dashboard by county. And as you can see from this heat map, that what we've seen in the past and what we continue to see is that the prevalence of cases happens more toward the east, toward the Atlantic, where we have more people who are in areas of population density and have less of the privilege of social distancing. Next slide. And what we're seeing here in this curve since the beginning, at one point when we began our conversations, we saw how this curve was rising and that we were continuing to see increasing numbers of those being tested. We're starting to possibly see a leveling off of this curve in the sense that the need for testing is only as great as the number of cases that continue to proliferate in the community. And we're starting to see that even though we've reached nearly 100,000 cases in the Commonwealth, the need for testing is starting to level off because our work that we've done in public health to maintain physical distancing and to keep folks safe has allowed us to continue to contain these numbers. And so that's a very positive sign. Next slide. In addition to that, something we continue to underscore in these conversations is that the percentage of cases, hospitalizations, and death by race ethnicity is really important. We hear in the media and in the news what's happening in different groups, in different neighborhoods, and in different groups of people. And with that, it's really important as we continue to think about the work we're doing in our own hospital systems to collect information about race, geography, primary language, ethnicity, et cetera, so that we have that information. It's just, quite frankly, said well in another conversation, it's not okay that we have 41% cases of race ethnicity that are missing and unknown. 30.9% of cases reported as hospitalized with missing race ethnicity data, and with deaths, 42% were missing race ethnicity, and that's really important for us to understand and to have recorded. So as many of us who are representing almost more than 20 hospitals over these 8 weeks of calling in to have these conversations together, let's continue to push for this in our hospital systems so that we have the information we need so that we can truly engage with and support and protect the populations of interest and greatest need. Next slide. Nicely, as we're beginning to move into recovery and reimagination mode in many of our hospital systems, many of us are moving out of the urgent response to COVID-19 mode. As we've had these town halls, we've had attendance across the board, as you can see, a number of different types of professions in terms of nurses, physicians, project managers, risk managers, social workers, midwives, etc. And that the town hall attendance has had a number of people, many of them, about 5% of people have come on to 4 or more town halls. The majority have seen one town hall, but have access to the town hall links on our PNQIN or Betsy Lehman websites. Next slide. We also have COVID-19 and pregnancy town hall attendance by a number of different types of medical centers. And as I mentioned earlier, this represents approximately 22 of our 43 birthing facilities in Massachusetts have attended these calls. Next slide. And with that said, we also had information that continues to come in from the Massachusetts Perinatal team, which is a group of our nursing leaders across the state, collecting information on deliveries, on L&Ds across Massachusetts of moms who are COVID-19 positive. And with that, we see leading at Beth Boston Medical Center, Tufts, Brigham, Mass General, BI, and that makes sense as we know that the populations at highest numbers often tend to be populations on the east side of Massachusetts, as we saw on the first heat map. As well, we understand that many populations, people of color, of Hispanic and Black non-Hispanic race and ethnicity are impacted, and those patients are often served at these hospitals that are listed here as well, nearly 50%, if not more. Next slide. And with that, as we move into what we're doing in our labor floors and what we're doing in our OB/GYN departments and thinking about recovery and reimagination and where we stand with COVID-19, it's nice to think about how do we use quality improvement to improve the care in our hospital systems, and how do we have some special tips around engaging in collecting data and using run charts. And with that, I'd like to introduce our colleague, Dr. Debra Bingham with the Institute of Perinatal Quality Improvement, who will review with us tips and ways of using QI to improve care in the time of COVID. And she'll give a very specific example, which will be helpful for us to think about how we can implement this type of quality improvement systems and metrics in our own hospital systems. So with that, I'll turn it over to you, Dr. Bingham.
Thank you very much. It's great to be with you all today. So next slide, please. QI saves lives. And anyone who's wondered what specifically is QI, if you go to the next slide, I like to use the definition of that was put together by the Hastings Center think tank. This was a special report on the ethics of using QI methods to improve healthcare quality. And they defined it as a systematic, data-guided activities that are designed to bring about immediate positive changes in the delivery of healthcare in particular settings. Next slide. They also said, and from an ethical perspective, that it's not purely discretionary for health professionals, managers, delivery organizations, patients, and government to, that it is not discretionary, that they all have ethical responsibility to cooperate with one another and to improve the quality of care. So I think your attendance at this particular session speaks to your understanding of your ethical responsibility to improve care. Next slide. But the problem is, many of us, including me, we've been around a long time. Maybe not all of you have been around as long as me, but anyway, but we've seen that there's a big gap between what we know and what we actually do. In fact, the IOM, and I haven't seen any data more recent or more current to debunk this, said that it takes approximately 20 years, 17 years to translate research into action. And I think part of that is because the QI methods, where not all of us have had a lot of education in how to implement changes. During COVID-19, during this pandemic, there's also a gap in what we know to guide what we do. So we don't want to ignore the research from the past of what we have learned when trying to do the best we can with little information. We don't want to cause more harm than good. And also, part of this problem is just when you're in the middle of a crisis, is sometimes it's like you're just trying to survive, but we also need to think about how do we learn from this, how do we improve? And in part of that is also making sure that we start to capture our data by race, ethnicity. And I did, many of you may have attended the Speak Up in-person training we did, the Speak Up Champions training. And there were many hospitals represented, and when we talked about whether you're tracking data by race, ethnicity, that is not something that most of you have been doing, and it's challenging. And so I recommend that this is particularly important to start to do at this point. And I know some of you who then attended our conference call, our post-training conference call, at least one hospital has started to track their data by race, ethnicity, and it was eye-opening. So it's one of these important parts of the work of QI, is to make sure that we are not further disadvantaging any particular group. And the way we do that is by tracking race, ethnicity data. Now, I know it's a bit messy. I mean, we don't all fit neatly into race categories, right? And but so what I recommend you find and usually it's the birth certificate data, how the person self-identifies, not a race that we apply to the person. Next slide. So one of the things that a lot of the professors at universities have not had QI expertise, have not had QI training. Most of the clinicians then don't get QI training. I was in a meeting in a different state, and I was teaching med students and nursing students, and I had them raise their hands if they had any QI education, and neither group has had any. Now, I'm at the University of Maryland in addition as an associate professor, and I know my main role there is to help expand QI expertise among the faculty, to help expand the ability of the DMP graduates and their skills around QI methods. So implementation science is relatively new. That includes implementation theories and frameworks. So even if people have had like basic QI, there's a whole nother depth to learning how to implement related to implementation science. And that's another, that's a topic for a whole nother day. We won't get into that right now. QI methods and concepts, I like to think about these as like process models and QI ethics. And I think what the main thing around the QI ethics is make sure you don't leave anybody behind. It's different than research. QI is different than research in that you want to make sure that you get 100% of patients receive evidence-based care. Goals and tools, setting, you have process map, fixed bones, logic models, driver diagrams. They're just tools. They're tools to help you be able to do your work of QI. I'm going to focus in on one particular tool today, and that's run charts. And so thinking about how you use data. So next slide. So first, the polling question is, are you proficient in creating run charts? And So yeah, so it looks like what I would expect, that about a quarter of you would consider yourself proficient, and others would say no, they're not. Some people might be saying, well, why do I need to know how to do run charts? I'm a clinician. But it's how you are able to track your data, how you can see trends over time, and how you can learn, especially during a pandemic. So I'm going to give you a really simple tool and show you this tool that IHI, the Institute for Healthcare Improvement, has created, that I think will, once I ran across it, I was like, oh, I can do run charts. So you don't have to have any fancy tools or any fancy education. I'm going to go through how to use this tool. Next slide. So tracking data over time, why does that matter? I mean, you could do before and after studies, but we lose all of this important information about how implementation is going, and also whether who we're impacting, who's not having any impact from the work we're trying to do. And that's why, and so you would track really structures and processes, and I use run charts primarily for process measures. Structure measures would be measures like, did you change the policy and procedure? How many people were educated? Did we change the electronic health record? Process measures would be, what are you actually doing? What's being done? And so that's the thing that you would track. And then outcomes would be, what's the outcome of interest? Next slide. So I put this together. We're going to back one more. Yeah, perfect. That's the slide. So I'm going to hone in on one of the issues we've had with COVID-19 is trying to figure out how to keep babies safe if their mothers have tested positive or if they have symptoms. And I know that was a big topic of discussion on more than one of these sessions. And I listened to last session and heard a lot of questions about the importance of shared decision making and making sure that there's conversations. And so I thought and it's an area that I care very, very deeply about, is keeping moms and babies together. I've done quite a bit of work on that over many, many years. And so I thought, let's just be real practical. I'll give you a real simple example of how you can use run charts to help you further understand and help us as a country know what should be done. So, so if we think about education, well, first, the goal is to keep moms and babies together. I mean, the babies go home with their mothers almost without exception. And so we also know that there's strong evidence that the benefits of immediate skin-to-skin and continuous skin-to-skin, especially during that first hour of life, is really critical. So we want to make sure people are educated on the importance of keeping moms and babies together, and also then on COVID-19 testing, which I think is now from what I heard last time on the call, most of you are doing that pretty rapid, doing that. There's some challenges around testing, so we can't completely rely on that. But anyway. So those would be examples of some structure measures. Then you would have your evidence-based process measures, which would be immediate skin-to-skin, continuous skin-to-skin, and then you would do your rapid cycle changes. Could be PDSA. MAPID is a type of process model similar to PDSA. Then you get to balancing measures, and in this case, we really would want to balancing measures like separating them. Is that really needed? And also and who was separated and how did that go? And we know that the outcomes we're looking for is improved bonding and breastfeeding. There can also be other types of physiologic benefits for skin to skin. Next slide. So I want to just point out where the IHI tools are, and again, you'll have access to these slides so you can find these tools. I have the actual link. So they're the run chart template. Next slide. Also, the IHI has these really great, if you haven't run across them, they're these whiteboard, they're like 5-7 minute little educational videos, and they go over how to do run charts. So everything you can do that, you can go back to these links and access those education. Next slide. So let's go to the breastfeeding guidelines. Right now we have a very unfortunate situation where we have a professional, national professional organization, the AAP, has much more, their guidelines are not necessarily in sync with the World Health Organization and with the CDC. So that puts all of us in this really kind of weird place of, well, what do we follow? And part of that is because nobody really knows exactly what's the best thing to do. So the CDC guidelines are that if you're breastfeeding and have symptoms or confirmed COVID-19, take steps to avoid spreading the virus to your baby. And the steps are: wash your hands before touching your baby, wear a face mask if possible while feeding at the breast, and then wash your hands before touching the pump. So if we apply that to, if we take the CDC approach and we apply that to immediate skin to skin, we'd want to make sure the woman is wearing a face mask and that she would wash her hands before the baby's skin to skin. Next slide. One of the things that's also helpful when you're creating your run chart is if people have already tested a measure and process measures, there's fewer of them out there that have been tested. This is a paper of my dear colleague who has passed, many of you may know, Mary Ellen Bovair. She was the co-author on this along with Ann Webb and Janet Murray, and who helped facilitate, and they're at the NPIC and National Perinatal Information Center. So we published our work on how to feasibility testing of the skin-to-skin measures from A1, which are immediate and continuous skin-to-skin. I know you can't see the details of the slides, but the reference is right there on the slide. And I point this out as we've done a lot of thinking and we did some testing. And so that will help you think about who do you exclude, who do you include in your population. Don't want to make it too complicated. So let's just go to the next slide. But wherever possible, use tested measures. That just helps you figure out your numerator and your denominator. But let's keep it real simple and let's just say our denominator is the number of full-term infants greater than 37 weeks that are healthy, and you exclude babies that are admitted to the ICU. So if they're greater than 37 weeks and go to the ICU, then you don't count them in your denominator. So that's the denominator, that's the population of interest. The numerator is the number of full-term healthy infants who, newborns who are placed skin to skin within 5 minutes of life. That's how A1 defined immediate. And or the number of full-term infants who remain skin to skin for at least 60 minutes. And that was how it was defined as continuous. And what we did for our feasibility testing is we did time on, time off. And you want to track this data by race ethnicity. So let's just say you go back, you look at Monday's data and you say 5 infants were born and placed skin to skin. Out of 10 babies who were healthy, not in the ICU, that were greater than 37 weeks. So then you would get 50% of the infants born on that day were placed skin to skin. And you could do either immediate or continuous. So you would do a run chart for immediate and a run chart for continuous. In this example, I said that that 5 of the infants were born to Black women, and 0 of the infants born to Black women were placed skin to skin. So, just wanting to, sometimes when we think about shared decision making, a lot of that is what people have been told, and the information gap can be pretty severe. And so we want to be careful that we also make sure everybody has the same information. And when we're talking about shared decision making around skin to skin, we need to be careful not to say that separating the baby is without any risk, because the baby being separated, I used to be a director of nursing. that baby has to be cared for by people who could also infect the baby. So it's not a no risk situation. It's different than tuberculosis, where in tuberculosis, we have healthcare providers who we have good tests to say that they're definitely negative. But multiple caretakers with this baby does affect some of the risk of what the baby could be exposed to, besides not having the early interaction with their mother and what that might mean for bonding. So we want to be careful about all of that. So let's go to the next slide. So here's the tool. So this is the tool I pointed out earlier. I pulled it out. Here's the reference. And it's an Excel spreadsheet. It's a little harder to see how easy this is when I'm doing like static screenshots. But basically, I wrote in here % immediate skin to skin and having the mother have a mask and also washed her hands. Then the number of healthy newborns greater than equal to 37 weeks born to moms with symptoms. And then you would put in the dates. I've left some of the dates not changed, so you can see you just put in whatever dates. If you were doing a week worth of data, you would put in a week. Whatever your date of observation is, you could choose 1 day a week, and just to save yourself just to have some snapshots of random times. You could do by shift. Then you would put in the %. So in the previous example, the % was 50%. The median, you don't have to calculate. In this case, I have 0, so there's nothing here. The median is automatically with the formulas in the spreadsheet, will calculate the median for you. The goal is you will have to put whatever your goal is. In this case, it's an evidence-based intervention, so your goal would be 100%. And you would want to make sure. So this is just 0 data has been entered in, but a bunch of dates are there, and it just shows you it automatically makes you a figure. So you don't even have to fill anything out. It gives you the heading, what you typed up here. It goes. This is your graph label, and then here's the vertical label that goes here. So pretty simple. Next slide. Just want to talk a little bit about benchmarks and goals, and also just wanted to highlight a couple of this new paper by Kramer on the Changing the Conversation, Applying a Health Equity Framework to Maternal Mortality Reviews. So again, I want to just emphasize, we want 100% of all of the patients to achieve the whatever the evidence base is. This is not research. This is QI, where we're trying to get the evidence-based intervention to all of the patients, and we shouldn't rest until we get 100%. Next slide. I'm sorry, on the last slide, I had goals versus benchmarks. That was to remind me to say a benchmark, you might have incremental benchmarks where you would be saying, okay, we're starting basically at 0. So in the next few months, we're going to get up to 25%, but our ultimate goal is 100. We're not going to stop till it's 100. Okay, on this slide, I filled in some data. And then you can see here, I made it a little funky, but where I went from 0 clear up to 100%, but mostly just to show you where you just put in these numbers, your graph automatically shows up, and then your median automatically will be calculated. And so your goal's 100, so here's where the 100 is, and then the median just is super, super easy. So then you take this data and you have this run chart. What you can do is then you just highlight the run chart and you can copy it and put it into a PowerPoint slide. Next slide. So here's just showing you, I manipulated the data further. I changed things around, and it just shows you another view of how easy it is. It's just the simplest tool. I've shown this in person to people, and like in the, as we're doing big educational session, and the room is like, oh, wow, you know, that's so exciting. So they're like, why didn't anybody show this to me before? Anyway, so it's run charts done, made easy. So that's my QI tip for the day. Next slide. I just want to remind you it's worth the effort, because QI does really save lives, and it really makes a big difference. So so with that, I'll turn it back over to, I guess, Audra, back over to the organizers. Thank you so much.
Thank you so much, Dr. Bingham. Every time I hear your talk, I gain more and more information. So this is really helpful each time. And I hope the same for those of you in the audience. So I want to say hello and welcome to our 98 participants on the call listening in. This is terrific, and I'm glad we actually have a treat for you, that we actually have patients who have agreed to come on and talk about their experiences of pregnancy in the time of COVID in their own words. I was going to say just that definitely we wanted to make sure that we maximize our participation before we had our patients' voice come on. So I'm glad that we're all here together. So without further ado, our recording of our first patient.
I had my baby April 17th, so I was kind of like in the middle of it. Even the rest of my pregnancy was different. I have had high-risk pregnancies, so I have to go and have the non-stress test done each week. So as things started, you know, progressing, we have to wear something covering your face. And then the next week it was like, now you definitely need a mask. And then the next week it was, now you need to have your temperature being taken. I'm a single mom, so like I have my 2 other children, and I used to bring them to the appointments with me. And then because of the pandemic, you know, they had to change the rules for people's safety. Like my oldest is 4 years old, so I kind of had to explain a little bit more to him, like, Mommy, why can't I come to the appointment with you? How do I have the right words to explain? So I just said, you're going to stay with Nana, and, you know, Mommy has to go to baby brother's appointment to check on baby brother, and, you know, I'll see you after. But sometimes I never knew, say you had a temperature, you know, so like that's the part that was like a little nerve-wracking, because I didn't feel any symptoms. I didn't like have any of that stuff, but in the back of your head, you're kind of just like, oh no, hopefully I do get to go see my kids after this. You know, they tell you to like not look online, because some things people are saying online may not even be what your actual hospital and doctor's office are doing. So I was just hearing like the horror stories that you'll be separated from your baby, and, you know, they'll test you right away. And then if you come back with any types of symptoms, even if you're like a suspect, and like suspect meant like if you came into contact with anybody that had it, or if you did leave the country, or if you had like all of a sudden you had a fever for like a completely different reason, then you would be handled a little bit more differently than the person who said no to all the questions. So, I mean, I had mixed emotions. For the most part, it took longer, obviously. And then because my older 2 kids were with my mom, and my mom still had to work, but it did make me feel safe too, though. So like I understood their protocol, and I understood like everything that they were asking me to do. It wasn't like what they were asking me to do was like unfair. Like I was fully dilated walking into the hospital, and they're like, have you traveled outside of the country? And I'm just like, I totally get that this is what we have to do, but I also am about to have a baby. I walked in the hospital at 3:01. And then once I actually got through all of the COVID questions, I finally got into the room. It was like 3:25, and my son was born at 3:56. I was trying to tell you guys, like they literally were just like, wow, that happened so fast. They let me be with my baby the entire time. Like he wasn't even weighed or anything like that until like 2.5 hours after he was born. So we were able to do skin to skin. He was able to latch and feed. that's everything I've ever wanted. So my other two were just like that too. So I really don't feel like anything changed in that way. If anything, because of COVID, I got to be with him even more. Even for the hearing test, it was my first time I got to watch the hearing test in my room with my baby. It was the coolest experience ever. Like, I was like, wow, I get to watch the hearing test. So this time it was like, no, we'll come to your room and we'll do it. You know, we don't want to risk him going in the hallways or anything. So he never left my room at all, ever.
How has COVID affected your postpartum experience?
It's been a little different. My older two, my son's 4 years old, and then my daughter is 13 months old. So I'm actually still nursing her. So I have questions about like tandem nursing and things like that. So they had a breastfeeding support group that they were doing virtually. I'm actually one of the only moms on there that has like multiple kids and who's tandem nursing. So they even ask me questions now. Like, they're like, hey, what do you think about this? And I'm like, oh, this is pretty cool. Like, you know, I feel like I have support for what I need, but also like I feel like I'm helping other moms too, like during this situation. So if you think about it, like because of COVID, we're able to have a breastfeeding support group virtually, because otherwise, like, how am I going to bring all three of my kids over to an in-person breastfeeding support group with all my kids running all over the place trying to talk about a clogged milk duct? Like, so it's like the fact that we have it virtually is like almost easier.
Is there anything else that you would like to tell providers? You should make sure you do this, or anything else you'd like to say?
Some people aren't going to ask questions. I feel like if I didn't speak up, maybe they weren't going to answer my questions about like this woman in New York or this, you know, because they don't know because I didn't tell them. So they think about it and like, hey, if I was in their position, what would I want to be told? And then the providers can think, hey, let's think of like 3 to 5 things that we can just tell them so that they feel reassured here.
And we're going to move now into our next recording.
I was living in Texas. I was pregnant and I had a stillborn baby at 25 weeks and 4 days. So I had a baby boy, call him baby DJ. My husband's name is DJ, so he's a junior. So yeah, I had him. Then fast forward, I moved up. So this was in June 1st, actually. So it's going to come upon his anniversary that I delivered him. And then I moved up to Boston July, and I got pregnant again. And my first appointment was actually at Brigham and Women. So my first appointment, I had a miscarriage. So this is my 3rd pregnancy. So I've been pregnant like for a long time, but this is my 3rd pregnancy. And, you know, as you can imagine, how devastating those losses were for me and my family, and, you know, the potential difficulty of going through times like this under COVID-19. Just being pregnant can potentially be scary for me with my past experiences, you know, but during this, it potentially gives room for anxiety and things like that. Going into the hospital, for example, my first appointment, I was wondering, should I go? I'm not sure. I don't know who has COVID there. It's pretty scary. I don't want to get it. I want to be safe. So I spoke to my provider, my doctor, and she was very reassuring that, hey, Erin, you can come in, wear your mask, you know, just have your gloves. It's actually very empty here. My husband is used to being with me and he doesn't miss any of my appointments. So I just kind of had my AirPods on and he was on FaceTime. So he heard everything, saw everything. And, you know, the appointment went great. My ultrasound was very smooth, but going in and actually trying to see her after instead of doing it on the phone, it was like night and day, because prior to COVID-19, there would be so many patients in the room, in the waiting room, and it would be like, okay, maybe 15 minutes wait to see your doctor. But now that it's COVID, there's like no patients in the waiting room, but then it's like this long wait time, like more than 30 minutes just to see the doctor. So I think for me as a patient, it feels like, I'd rather just talk to you over the phone, because I don't want to be in the vicinity of, I don't want to be touching the door. I don't want to be sitting down in a room that long. I actually have a general list of things that I wish they do differently for all the doctors and the nurses and the techs and even the secretaries, anybody that works in a hospital. It's just so important to the patients for them to feel comfortable, for them to feel welcomed and understood. And like, obviously I didn't think I'd ever go through something like this, but I have. My nurse, she wanted to know what happened to my stillborn baby. And I told her what happened, and she asked, like, what happened to the baby? Did they ever figure out anything? And they didn't figure out anything. They didn't do they ran tests all over me, but they didn't test the baby. And so, my doctor in Texas felt like, the baby's like an angel, protecting me from something. That's what she said, right? And so I was okay with that. That was fine for me. So I explained that to the nurse, because she was the nurse here in Boston, and she just busted out laughing. Like, she just uncontrollably laughed. And it was so inappropriate, because it's like, I'm talking about my baby that I just lost, and you find it very humorous what the doctor said. I even have like a channel where I am talking to other women. It's called Chosen, talking to other women about, my story, and putting it out there, and things. I have a video on things to say and things not to say to someone who has lost their baby. So I'm just kind of like embracing this time, and I would like to inspire and motivate other people with my story. And during COVID, I'm not going to be afraid. I'm not going to be silent, and I'm not going to be, I'm just going to be fearless. I'm going to be bold. I'm going to be great. And I'm going to move forward with what is in me.
Thank you. That was wonderful to hear the stories from women who were experiencing being pregnant in the time of COVID. With that, I'd like to turn this over to Dr. Iverson to talk about our question and answer session. I just want to verbally say thank you to the women who have taken their time to bravely come on and tell their stories to our audience.
Great. Thank you, Audra. Thank you, Dr. Bingham and Barbara and everybody, and especially thank you to our patients who've been able and willing to come and share with us. And I have some questions for the patients and for Dr. Bingham, and I encourage people to type in questions into the chat box as well. We'll try to keep an eye on that. So first, I just wanted to ask patient number 1. Again, congratulations and thank you for sharing. Would it be okay, could you just tell us a little bit about what makes you feel supported, especially around the COVID epidemic, both inpatient and outpatient, how we can ensure that we're helping our patients feel supported, both in the telehealth or outpatient experience that you're having, as well as when you're in the hospital. And I think we'll take you off mute.
Yes, I just did. Thank you. Yeah, so I mean, I had mentioned that I'm in a breastfeeding support group. So my hospital actually offered that to me where I delivered, and they said, because I had a couple of issues with the tandem nursing. So they said, hey, we have a breastfeeding support group virtually. Do you think that would better help support you? And I said, yes, absolutely. So doing that once a week, we have our meetings every Tuesday, and we do it through Zoom like this. So that has been super helpful. In general, like if I have any questions, I usually just call over to my doctor, and then they've been super supportive through telehealth. If it's something that obviously is like needing me to go in. So for instance, coming up, it'll be 6 weeks. So my postpartum visit will be coming up. They've called me, they've reassured me saying, we're taking all precautions, but of course I'll be needing to come into that appointment. They have assured me that nobody has, they're moving all the chairs, quite as distance apart. I believe all the chairs are about 6 to 12 feet apart from each other. So if there's anyone in there, they did tell me that there wouldn't be appointments scheduled so close together, so that, just for more safety precautions. So they've already pretty much called me and told me all of that. Then again, they will call me another time right before the appointment starts. So I just feel like communication, overall is just what's the most important. So making sure that, the patient's reassured, but even making sure the patient is being communicated to them as well for the providers, so that, you can all be on the same page moving forward. But I really do think, that's really all we can do right now is just be very open with each other and be there for each other in any way possible. So.
Thanks. Just a follow-up question. It sounds like the answer to all this, as usual, is communication. Is there any point where there gets to be too much communication, or have you had in situations where you've noticed an inconsistency in from one space that you're receiving care to another, and ways that that's affected you, or ways you feel like that could have been done better?
Yeah. So, my situation, I have hypothyroidism as well. So I have an endocrinologist that I see. So he has me on telehealth. But, for some circumstances, like I had to go in for a physical, ironically, all during this time, that's when my appointments were. But, I have 3 children and I'm a single mom. So trying to make sure I can have childcare available, so that my children aren't coming into the appointments with me. Some places, like my endocrinologist was like, yeah, we definitely can't have any of your children coming into the appointments. So, which is why we had a telehealth appointment. But for my physical, they allowed my newborn to come into my physical with me. My older 2 had to stay with my mom. But for instance, that made me feel better because I'm breastfeeding my newborn. So I was a little nervous, like leaving him to go to the appointment. And then for my upcoming postpartum appointment, he's not allowed to come with me. So it'll be my first time leaving him with my mom. And I pumped some milk so that way, he can be fed and everything. But, so some doctors in different locations are saying, okay, yes, you can bring your newborn, but definitely not the older 2. For calling me with all the questions and everything and giving me like kind of a sense of reassurance, I'm fine with that. Sometimes they call me, one day and then they'll call me the next day and then they'll call me the day before. It's not that it's too much. It's almost like it's good that they're doing it, in my opinion, because it makes me feel like they're on top of it, and like you don't have to question like, well, what are they going to do if I come in this, and nothing's changed really. So they're just giving that update of, it's still going to be the same, just have a mask on. It's the same if I bring my son to his newborn appointments for pediatric care, have your mask on. So I don't feel like it's any over communication. I think everyone's pretty much on the same page, and it just makes me as a patient feel more reassured. Obviously the only difference is like some allow the newborn to come, some don't. but it also depends on the types of things they're doing in the appointment. So for my postpartum care, you know, it would probably be better if my newborn was with my mom so that they can get everything done, you know, in a timely manner. But yeah, I think it's a good thing that we're all talking.
That's so helpful. Thank you. You know, what I'm hearing there is that if we as providers present the same information every time consistently, it's reassuring and really helpful. Changing the expectations and what we can do for you here in the hospital, particularly on childcare, can be difficult. I wanted to thank you so much. I wanted to ask a question of Erin, and thank you, Erin, for sharing with us. I really appreciate it. I'm just wondering, in the hospital, what do you look for to feel safe? Well, number one, as a patient, obviously, we're always concerned about that. Particularly, we're talking about COVID here. Like, what makes you feel safe as a patient when you're in the hospital?
Well, with my experience with going in the hospital, and I obviously wear my mask and my gloves, and I bring wipes to wipe down anything that I touch, even like a pen for the elevator. I don't want to touch anything, you know? What makes me feel comfortable is everybody taking that precaution, and I think they've done well with that, like going into the ultrasound and not much people there and not much waiting there in the ultrasound. They're pretty quick. And they also, what makes me comfortable is that they wipe everything down like in front of me, you know, because I'm just that type of person. And it makes me comfortable that I can FaceTime my husband and that it's not a big deal, you know? And then I would say with going to see my doctor, what makes me uncomfortable, I know you're talking about what makes me comfortable, but what makes me uncomfortable is the wait time and the fact that I have to open the door and wipe things down. And it just kind of feels like everything's back to normal. It doesn't feel like there's a precaution there in the doctor's office for me. So that would just make me more comfortable if the wait time was shorter, because I'm the only one in the office. Normally there's plenty of people, but I'm like the only one there. So it's like, what's taking so long? And getting in and out and wiping things down and things of that nature.
Well, that's really helpful. I have to say, we knew it would be wonderful to have patients contributing, and you guys are both really helpful. Thank you. I want to ask a question also of Dr. Bingham. Thank you so much, Debra, for coming on. I guess, you know, one of the things we've been thinking about here for all these town halls is we always want to do stepwise approach and thoughtful approach to whatever we're implementing. What are the key, in your experience, what are the key steps for implementing something in this time of sort of rapid change and rapid evaluation? Like, do you have any words of wisdom about how to do that quickly and completely that you could take us out of here on?
Well, I think for me, the biggest thing is what's the problem I'm trying to solve? So having clarity around the problem that I'm trying to solve then helps pull, and also what's my goal? Then that helps me figure out, so like all of the things that I work on, I have like specific thing in mind I'm trying to achieve. And then I try to, if I could have a structural change, then I'll fix that. And what I mean by that is figure out if it's as easy as changing the electronic health, and I know that's not easy, but it's still easier than sometimes getting a whole bunch of people to change how they act. If there's something structural I could change, like you dig a ditch, that's where water will go. So is there something I could do structurally? And so policy work all the way down to, you know, like high level policy, state policy versus unit policy. And then it's like, also I have to have clarity around what exactly do I want people to do? So in order to get the outcome I want, I need to articulate specific behaviors. And so like for the OB hemorrhage work that I did, that toolkit, it broke it down into very like 5 specific things I wanted people to do. And once I laid those out, then I give them tools. How do I make this easy to do that? You know, so what's the problem? The problem was people were dying of hemorrhage that didn't need to die. What were the things that people need to do? There's 5 things we need to do better. And so and then how do I help you do those 5 things? I give you a bunch of tools that make it easier for you to do those 5 things. So anyway, it's like, I don't know if that helps, but I did spend years telling people not to put things under a cupboard, like under a sink. And I went around years doing that until one day I was like, well, just lock the stupid sink, you know, the cupboard. And it was the kind of lock that you could pick in 5 seconds, right? But it was a structural change. So again, go back to if you could do something structural to get things done right. I don't know if that's helpful. Data's very powerful for leading change too. And you know that, like showing people where they're at and what, and honestly, in one time, all I had was I put up some graphs. I would, every month I'd put up this graph in the NICU around pain, how many babies had their pain scores tested. Or documented, and every time I put it up, a few people were around me and I said, all right, we're still not doing very well. That data then drove them to change. It was, I didn't have time to do much more than that, but they, all of a sudden it opened their eyes to something they should do better. So anyway, those are some quick tips.
No, that's awesome. Thank you so much. Totally appreciate it. And to you and everyone who's contributed, I'm going to pass it on, my thanks, and I'm going to pass it on to Audra and Barbara.
So Audra, are you there? I think we were just going to wrap up and say thank you once again and goodbye. And, you know, I just want to echo Audra and Ron's thanks to both of our patient presenters. The stories, you know, your stories are always what, they're always compelling, they're always grounding, and you know, and we know that it's not always easy to step up and tell them. So really, really appreciate that. Our next town hall is going to be in 2 weeks. We've kind of gone to an every other week cadence on these. So that will be June 9th, and we'll look forward to seeing you then. The final thing is we'll keep the chat box open just for a couple minutes. So if any of you are attending and are not on our distribution list and want to be added, all you have to do is type in your email address, and we'll make sure that we add you to future invitations. And Audra, I'm not sure if
I am here. Yeah. And with that, I'd like to
Great.
just say thank you. Yes, to our presenters and our wonderful information, and to say that we're here to be supportive of teams who are interested in moving forward with collecting data for run charts and QI for their divisions, as this could be helpful to you moving forward for your policy development. So thank you for your time.